Well, thanks all for asking me to come and talk about infection in CLL, and this is an area that I'm quite passionate about and intend to sort of focus my career around how we can improve the situation in patients with CLL. Not working. It's a good start. There you go. Okay, so as you know, nowadays a lot of patients with CLL are picked up incidentally, so around 70% of people are detected at an early stage in their disease, where we'll give them the diagnosis of CLL and then we'll say, well, we're just going to monitor you. And that watch and wait obviously causes a lot of angst, understandably, but actually what's probably important to pick up at this point is the fact that even at diagnosis, immunodeficiency is actually present in around 25% of patients that we diagnose. And if you look back at that initial consultation and actually ask patients, a lot of them have suffered quite a significant amount of infection before they've even got to the point that we're diagnosing them with CLL. And particularly things like herpes zoster infection, so shingles and reactivation of the chickenpox virus, it's a real problem. So there's been a lot of data out there over the decades to show that patients with CLL suffer from infections more than the background population. But I just thought I'd present this data that was literally published just 2 months ago, which is probably the biggest database to date of 2,900 patients from the Danish registry for CLL. And they actually looked to see what the incidence of infection in patients with CLL at diagnosis and followed them up over time. And even those that we were just watching and waiting and not giving any treatment to, they found the incidence in the first year post-diagnosis was 12%. And of those, 9.8% died within the first 30 days of having an infection. Now, they defined having an infection as the presence of having had a blood culture taken, whether it was positive or negative. But generally in hospital, we would only be doing a blood culture if patients had significant fevers or were showing symptoms, signs of infection. So it's a good surrogate marker. And even more worrying perhaps is that a quarter were actually dead within a year. Now, I'd say the caveat to this is that actually they didn't take comorbidity into consideration, and a lot of patients with CLL have other comorbidity and other illnesses that would have contributed to this. And the other thing we don't know from this database is actually what the background population mortality was at the age match for it, because that isn't available in the paper either. So although these are quite shocking statistics, there are other caveats to them I think we need to appreciate. And the 5-year incidence overall in untreated patients for infection was around 31%, which is similar to data that I'm going to show you now that I've collected within the West Midlands. That's not really working, is it? Any idea why that's jumping up and down? Let's try and do it. It seems to have frozen on there. This is going to be a slow talk.
Sorry about that.
No, that's okay. Okay, so types of infection in CLL. These can be very broad and vary between bacterial infections and viral infections. The ones that cause a lot of bother in patients with CLL are what we call the encapsulated bacteria. So these are bacteria that have got a sugar polysaccharide coating around, and it means that our immune system can't deal with them very effectively. So the main one in that category that we worry about is pneumococcus, which causes, is one of the major causes of pneumonia. And also increased mortality in patients with CLL. Other viral infections are shingles, as we've already mentioned. Flu and common cold viruses are also a problem. And then we also are seeing opportunistic infections in the context normally of therapy, but also even with the new novel agents, these are still proving to be a problem. So with idelalisib, we're seeing Cytomegalovirus, which is another type of herpes virus like shingles that can reactivate. So we're seeing that with idelalisib, and there's a warning on that now that we need to be monitoring patients for it if we're starting that drug. And also PCP, which is another type of pneumonia that you only see in an immunocompromised setting. So what are the causes of immunosuppression in patients with CLL? Well, it is multifactorial. There's hypogammaglobulinemia, which just stands for low antibody levels, and that can be seen in up to 85% of patients with CLL over time. It's present in around 25% at diagnosis, and it will progress over time. And all different subclasses of antibody have been shown to be effective, of which there are 5 main types. The other problem is a problem with the cellular immune system, so the way that our cells are able to deal with infection, and this is termed T-cell dysfunction, and that's important for infections that are within the cells, such as viruses. Other causes are immune cytopenias, and that means that you've got low numbers of your immune cells that would fight infection, so things such as neutrophils that you might have heard of in terms of neutropenic sepsis, well, they can be low anyway in patients with CLL without therapy being involved. And then the other cause is therapy, so we come along and treat people with chemoimmunotherapy and make you even more suppressed, but also, it's not quite on the slide, but let me see. But the novel agents too can cause their problems, as I've already mentioned, with PCP and CMV reactivation. But paradoxically, I think there is now some data to suggest that the new agents can actually improve the situation. Certainly with ibrutinib in the first year, we're seeing less infections, and then the amount of immunoglobulin A seems to go up on patients with ibrutinib, and that is a surrogate almost for some protection against infections. And then also with sort of data that I'm accruing in the lab at the moment, I would say as well there's good suggestion that the cellular immune system is improving on patients with ibrutinib as well, but haven't got around to publishing that yet. So this is some local data in patients with CLL that I collected. So these were from Heartlands Hospital and QE Hospital, 56 patients. 35 were untreated in a stage A, and these had quite a long follow-up time, so the median time follow-up was 7.8 years. Over 50% had a documented infection in the hospital records, and 22% had a positive sputum culture that I could identify. 27% had more than or equal to one admission related to infection, and the majority of these were your pneumonias and your lower respiratory tract infections. And over a third had immunoglobulin G concentrations below the lower limit of 6 grams per litre. And as clinicians, we often look at the IgG level at diagnosis to give us an idea about how immunocompromised patients are. And this is probably the most staggering bit of what I collected actually, in that just under a quarter were actually unvaccinated against pneumococcus. And only 3 had actually been given Prevnar 13 conjugate vaccine, which is what is recommended. But I'll come on to explain a bit more about that just now. Okay, so a bit on types of vaccination. So many bacteria, including pneumococcus, as I mentioned, have got this outer sugar polysaccharide coating, and that disguises internal bacterial antigens, so you can't see them very well. So our most effective defence that we have against this is just to coat that bacteria with antibody that recognise that sugar coating. But in immature immune systems, so in babies less than 2 and in patients with CLL or other immunocompromising conditions, that response is known to be poor. And also, if you treat patients with a polysaccharide-based vaccine, similarly, you get a poor response. So instead, what scientists obviously have come up with is a conjugate vaccine, and this means where you tag a peptide or a toxoid that the immune system is good at recognising, such as diphtheria or tetanus toxoid, and you link it to that sugar coating, and that then helps the immune system to recognise, but more importantly, form a memory response to that polysaccharide antigen. And in patients with CLL, we know that those type of conjugate vaccines actually generate a much better immune response compared to polysaccharide vaccines. So the type of conjugate vaccines that are available are Prevnar 13 against pneumococcus and Monitorix, which covers Haemophilus B. And I think for the first time, this is in February 2018, we've always hoped that if you managed to get a response to a conjugate vaccine that would persist, but we now have evidence actually from this publication that it can persist in up to 70% even 5 years later in the context of CLL. So it's really important that we're trying to get that immune response and we're using the right vaccines, and then if we manage to get an immune response, it should be there and should be long-lived. So how can we measure the immune response? Well, in the clinical lab at the QE and across the country, you can measure what we call functional antibody levels. And these look at the common bacterial antigens that we come across, and specifically whether we have antibodies that recognise those specific antigens of those bacteria. And the WHO set out criteria which tells us exactly whether you've got a competent immune system against those or not. So using the 56 patients that I'd collected over the past few years, we looked at what the functional antibody levels were in patients with CLL compared to healthy age-matched donors. So if you just focus on these two columns, this is healthy donors that are age-matched over the age of 65 that had never been vaccinated against pneumococcus. And you can see the ones in bold are the ones that have got an adequate, by WHO standard, protective level against these different types of bacterial antigens. In comparison, here is the CLL population, and you can see there is actually only 3 that reached the required criteria. And all of the asterisks down the side here represent the difference, a significant difference between our unvaccinated healthy donor population compared to our patients with CLL. So it really shows that, you know, at an antigen-specific level, we're not getting an adequate response against these common bacterial antigens. But having said that, as I've said already, we haven't vaccinated appropriately in the majority of these patients. So this slide looks very busy, but it represents all of the different types of serotypes that we can test for using the functional antibody testing. But it shows if each one has a normal IgG and then patients with a low IgG. And there is a bar on each of these, it doesn't really project very well, that shows where the WHO criteria for inadequate response is. And essentially, even if you've got a normal IgG level, you may well have deficient antibody responses against these common bacterial antigens. So taking a total IgG is not really sufficient to say whether you would have an adequate response against these bacterial infections should you come across them. So the conclusions from that work really were that antibody dysregulation is very common and that poor vaccine uptake is actually an area of concern. But I think there's this question about who takes ownership for vaccination in patients with CLL. Is it the GPs? And can we expect the GPs really to have the in-depth knowledge on which vaccines they should be given to patients with CLL? Or then is it the haematologist, and should we be vaccinating in clinic, which then brings a lot of costing into it and the means by which we do this, which is beyond me, but it would make life a lot easier, I think, if we were able to just vaccinate in clinic when we saw patients. But the onus, I think, is on us and patients as advocates to actually inform GPs as well, if it is going to be where primary care is where the vaccination takes place. So I think we need to work on local vaccination policies in terms of making them more clearly defined and make sure they're being adopted. And then finally, I think the functional antibody levels do add additional information to just the total immunoglobulins that we would normally be performing in clinic. So in terms of what is guidance currently, so patients, when we diagnose, should all be given a total serum immunoglobulin level at diagnosis, and that should be documented in the notes. At diagnosis and the earliest possible opportunity, patients should also be given Prevnar 13. And we know the earlier we give this, the better chance that we're going to get an adequate response. The guidance then says that at least 2 months later, patients should be given Pneumovax 23. The evidence for that is actually poor, but that is within the green DOH guidance for how we should be vaccinating patients with CLL. The Pneumovax 23 is a polysaccharide vaccine, so you can see why I'm reluctant to be, without the evidence saying we should be doing this, but this is the current guidance. And the Pneumovax 23, as for healthy elderly, healthy over 65s, should be given every 5 years. I think in our cohort that we looked at, the ones that had actually been given Pneumovax 23 were patients that were over the age of 65, so the GPs had routinely given the Pneumovax 23 vaccine. And I think that's probably where that's come from, but it's, as I said, I mean, Prevnar 13 should be what we should be given first of all. Then Meningitis vaccination would cover Haemophilus B, which can also cause pneumonia, and then the annual flu. And I would also say to check the routine vaccinations, because I know from the work that we've done, diphtheria, tetanus, if they haven't been given within 10 years, they should also be given. So avoid live vaccines, I'm sure you all know. That includes the current shingles vaccine, but I just wanted to mention that there is a new recombinant vaccine out called Shingrix. It's not contraindicated in patients with CLL, but there isn't the safety data available yet, but I think it will be forthcoming. If patients then are still symptomatic with infections after being vaccinated, this is where I think it's really important that we should be checking the functional antibody levels against that vaccine, because if we know that you're not responding to a vaccination because we've got evidence that the functional antibody level is inadequate, then that means if you come across that infection in the community, you're also not going to be able to mount a proper immune response towards it. And that should highlight to us that we should be looking in patients that are getting recurrent infections to commence prophylactic antibiotics. You can look for functional antibody levels as early as 6 weeks after vaccination, so it doesn't need to be a prolonged wait before we can confirm that. And then in patients who have prophylactic antibiotics and they're still getting infections after 3 months of therapy, then we can also give intravenous immunoglobulin. And that is pooled antibody that we've collected from healthy donors and should give a good immunity against commonly encountered community infections. And it's important once we start this, it's given normally every 3 to 4 weeks, that we then check the trough levels of the immunoglobulin to make sure we're getting that within normal range. So in conclusion, I think infection in CLL is very common and it's often overlooked at diagnosis when we see patients and first diagnose them and they seem very well and we tell them we're just going to watch and wait. I think immunisation is most effective at diagnosis, and there's our window of opportunity to get the immune system as geared up as possible. And conjugate vaccines are our best chance of getting the response to against those organisms. Prophylactic antibiotics and IVIG can also be important, and I think there's a lot of research needed to improve infection prevention in patients with CLL. So here's future work that I think needs to be done. I'm wondering whether we should actually be looking at giving prophylactic antibiotics during treatment for patients with CLL, because the recent myeloma data suggests that if you give levofloxacin antibiotics during the first 12 weeks of therapy, that actually has a much improved outcome. Optimising vaccination strategies, this is something that I'm trying to set up in Birmingham at QE. So in neonates, we use Prevnar 13, the same vaccine that is recommended in patients with CLL, and we give more than one vaccine. So we will booster to improve that memory response. There's no data out there in patients with CLL as to whether that would help or not, but there is in other what we term secondary immunodeficiency conditions, and it almost doubles the improved response rate. So I'm fairly sure that that could be a good step forward in patients with CLL. There's not clear pathways currently between primary and secondary care and information going between the two, and I think that also is an area that we need to concentrate on. And then education, just educating patients and haematologists that the earlier we vaccinate, the better the response. And for patients suffering from infections, there are other means such as antibiotics and IVIG that we can improve the situation with. Now, I just said I'd mention this. So this has just been set up in Birmingham, if anybody is interested. It's involving patients in cancer research in Birmingham. It's a recent group. They've only met once so far, and they're looking for more members. You can be remotely involved if you don't want to attend the meetings, and the aim is really to ensure that we have a patient voice that is integral to all of our research at university. I think that's really important going forward, and it's definitely something that the funders are also looking for now. The idea is that you work alongside the researchers and you'll review documents either by email or give us feedback over the phone about project ideas that we come up with, and also patient information sheets, whether you would find it useful, whether you've got any suggestions of how we can improve things. And also, even if you don't want to get involved in that, if you would just like to receive emails regarding the research that's going on, you can ask just for that side of things as well. So there's 2 email addresses there for Karen and Margaret who have set this up. Okay, and then just some acknowledgements at the end. Thank you.